Hi, guys. Welcome to the Pathology series initiated by the International Student Union in LFHK. My name is Revati and I'm a sixth year medical student. In today's presentation, we will be covering the topics of growth adaptations, cellular injury, and cell death. We will be looking at what are cellular adaptations, the different types of cellular adaptations, the proliferation involved with labile, stable, and permanent cells, the types of regeneration, the mechanism behind cellular injury, the types of cell death, along with the types of necrosis. So, to begin, what are cellular adaptations? Cellular adaptations are reversible changes that occur in cells with respect to their size, the number, and the function caused by physiological or pathological stimuli. So, here we can see that we have examples of physiological stimuli and pathological stimuli. So, the first example for physiological stimuli would be the increased muscular mass after exercising. So, during exercise, there is a potential to damage these skeletal muscle fibers. And the way the body responds to this is by increasing the size of these muscles. Because one of the specific features with regards to skeletal muscle fibers is that there is no potential for regeneration. So, once they're damaged, the only thing that these muscle fibers can do is grow in size in order to cope. The next example we can see is the increased number of epithelial cells during pregnancy. So during pregnancy, we need to have increase in the number of epithelial cells in order to support the growing fetus inside the womb. If we don't have this increased number, then the fetus will not be able to survive. And now we come on to pathological stimuli. So here the example given is Barrett's esophagus due to chronic gastric acid exposure. Now, Barrett's esophagus is a precancerous lesion to developing esophageal adenocarcinoma. So, essentially, what happens with Barrett's esophagus is that we have changes in the epithelial lining of the esophagus. So, normally it is lined by squamous epithelium, and this gets converted to columnar epithelial lining, which is seen in intestines. So, it is basically called as intestinal metaplasia also. And the reason why we have this change in the epithelium is because of the chronic gastric acid exposure. So the body and the way the cells can get used to this acid exposure is by changing the type of their cells in order to better cope with this stressor. So now here we have an overview of the different types of cellular adaptations that take place. So we can see the morphology and how the structure of the normal cells look like. So they're square and they have a nice round nucleus. So in the case of atrophy, here you can see and differentiate the differences between the normal cell and the atrophic cells. So you can see that the atrophic cells are reduced in their size. So they're of the same morphology, they look the same, but it's just smaller than the normal cells. In the case of hyperplasia, you can see that the number of cells have in fact increased. So here we can see 4 cells, but in fact here you can now see 6 cells. So this is basically what we define as hyperplasia. It's an increase in the number of cells, whereas atrophy is a decrease in the size of the cells. And in hypertrophy, it is the opposite of atrophy. So it is basically an increase in the overall size of each cell. So compared to the normal cell, we can see that it has grown in size. And metaplasia, in fact, is more of a programmed, it's a reprogramming of these cells in order to change their shape and their features. So an example that we discussed with regards to metaplasia was on the previous slide about the Barrett esophagus. So we spoke about how we have the squamous epithelial of the esophagus that gets changed into the columnar epithelium of the intestines in order to better cope with the gastric acid exposure on a long-term basis. And here in dysplasia, we can see that we have a disordered growth of these cells. So their features look completely distorted. They don't look anything like the square shape that we see in the normal cells. They have taken, each cell has taken on its own shape, and this is what dysplasia is defined as. And also in metaplasia, we could also see that the shape of the cells have completely changed. We will be talking more in depth about the different types of cellular adaptations. So the first type will be atrophy. Now in the previous slide, I mentioned that atrophy was an overall decrease in the size of the cell. So here we can see the morphology of how the normal cells look like. They look uniform, they're square in shape, and they have the nucleus in the center. But in the case of atrophy, you can see that these cells get compressed to a more rectangular configuration, and even the nucleus are compressed along with these cells. So now we can usually divide atrophy into physiological atrophy and pathological atrophy. In the case of physiological atrophy, the example that we can take is the uterus decreasing in size after birth following the cessation of production of hormones which stimulates its growth. So like I mentioned in the previous slides, that the increase in the number of epithelial cells during pregnancy is essential in order to support the fetus. And we also have a number of hormones that are playing a role in order to increase the size of these cells. Now, after birth, the uterus doesn't need these increase. They don't need the increased size in the cells in order to support anything because the fetus has already come out. So, this is an example of its physiological atrophy. And in the case of pathological atrophy, we have many examples. So, one would be the atrophy of disuse, where you have decreasing functional demands which lead to muscle atrophy. And this is actually considered to be reversible with activity. So, when you're not using these specific muscles, or let's say you're in a state of immobilization after some trauma, then these muscles undergo atrophy because you're not using these muscles on a regular basis. But once you start using these muscles, they undergo hypertrophy, so they go back. Hypertrophy is physiological in this situation because it is the way the body responds to this situation of activity. So, like I mentioned here, this is normally reversible with activity. So, when you perform activity after the state of immobilization, then these cells grow back, go back to increasing in their size and looking like the normal cells. Another example would be the denervation atrophy, where the loss of innervation leads to muscle atrophy. So, here the example is carpal tunnel syndrome. So, carpal tunnel syndrome is characterized with median nerve compression, and median nerve is responsible for supplying um, innervation to the thenar muscles of the hand. And if this nerve gets compressed, then the muscles that are innervated by this nerve would not be in use. And this is an example of denervation atrophy. The last example is atrophy of an endocrine organ due to loss of hormonal stimuli. So, an example here would be the atrophy of, let's say, the thyroid gland, because the pituitary gland, which is initially atrophied due to some trauma or any other reason, stops producing the hormones required for the thyroid gland in order to produce the T3 and T4 hormones. So, if the pituitary gland is not functioning, then eventually even the thyroid stops functioning because they have a lack of stimulation from the pituitary gland. And this is an example of the third situation. Now, atrophy can also be divided into hypertrophy, or which is otherwise known as simple atrophy, and numerical atrophy. So there are two types of atrophy that we can also mention, and I've not mentioned in the slides here, but I'm just going to explain it. So simple atrophy is a situation where we have degeneration of the tissues, which is caused by a decrease in the protein synthesis and cellular content, like the organelles and the cytoskeletal all get decreased, and this is results in degeneration of the tissues. And numerical atrophy, in fact, is decrease in the number of cells, not the size of the cells but the number of cells, and this happens through mechanisms of apoptosis, which we'll discuss in the next coming slides. So now we will differentiate between hypertrophy of the cell and hyperplasia of the cell. So hypertrophy is an overall enlargement in each cell size compared to the normal sizes of the cells. And hyperplasia is characterized by an increase in the number of cells. So if hypertrophy is the size and hyperplasia is associated with the number of cells increase. So here again, we will explain a couple of the examples with each cellular adaptation. So the second cellular adaptation we'll talk about is hypertrophy, and the examples for this would be right ventricular hypertrophy in response to pulmonary hypertension. Now, in the situation of pulmonary hypertension, there is increased resistance within these pulmonary vessels. So the right ventricle needs to contract much more harder in order to push blood against these pulmonary vessels and supply blood that is yet to be oxygenated to the lungs. So, in attempts or in a way to adapt to this pulmonary hypertension, the right ventricle undergoes hypertrophy. So, it increases in its size. Each cardiomyocyte increases its size in order to be able to perform greater work against this pulmonary hypertension. Another example we can see here is the increased muscle mass through sport that I explained previously, and actually an unique exception would be the expansion of the pregnant uterus, which in fact is considered to be a combination of hypertrophy and hyperplasia. So this is one of the examples, and an exception, a very good exception to the entire rule. Now, examples of hyperplasia of the cell, which is the third cellular adaptation that we're going to talk about, is one of the first examples would be the proliferation of the endometrium under the influence of estrogen during the menstrual cycle. And another example would be the thyroid goiter in response to iodine deficiency. So, when you're in a state of iodine deficiency, the thyroid gland enlarges in order to try and capture all the iodine it can in order to produce the thyroid hormones. Because iodine essentially is obtained mostly from the diet, and that's why the thyroid gland undergoes enlargement. And example of a pathological situation of hyperplasia would be the epidermal thickening that is seen in a skin disease known as eczema. So the next cellular adaptations we will be talking about is metaplasia and dysplasia. Now, metaplasia is characterized as conversion of one cell type to another. So it's basically as a response to a stressor. So here you can see in the image, these are the normal configurations of the cells, and then we have the changes in the morphology of cells completely. And we discussed a previous example about Barrett's esophagus, or otherwise known as intestinal metaplasia, with regards to chronic exposure to gastric acid and the acid reflux that occurs. So the other example that we can talk about is with respect to smoking. So we have the bronchial pseudostratified ciliated epithelium that becomes stratified squamous epithelium in response to the cigarette smoke and to be able to better cope with this stressor of this toxic substance. And in the case of dysplasia, dysplasia actually is not considered to be a true adaptive response, but it is defined as a disordered growth of the epithelium, and it is characterized by many cellular changes. So, one, in the image, you can see that these cells have very different morphology compared to the normal looking cells. So, and there are many more cells compared to that of metaplasia. So, dysplasia is characterized by pleomorphism. We have abnormally frequent mitotic figures, which is basically a high number of these mitotic figures indicates that there are rapidly dividing cells, and it could indicate that this could maybe be a precancerous lesion. We also can see an increased nuclear to cytoplasm ratio. So here we can see that the ratios of the nucleus to the cytoplasm are proportionate, but here there's less cytoplasm for the overall size of the nucleus. And also we can add another cellular change to dysplasia would be the clumping of the chromatin. And dysplasia is characterized to be a precursor to cancer. So we have, for example, the cervix and the respiratory tract. So we have epithelial cells of the cervix. So the precancerous lesion for cervical carcinoma would be your cervical intraepithelial neoplasia, and the same would be the precursors to cancer in the sense of epithelial cells of the respiratory tract. So we could eventually end up causing bronchial carcinoma. The next type of cellular adaptation that I'll be talking about is proliferation. So the three types of cells to focus on are labile cells, permanent cells, and stable cells. So labile cells are in fact very short-lived cells but have the potential to rapidly divide. And these cells can typically be seen in the mucous membranes of the gastrointestinal and respiratory tracts, the skin, and the hematopoietic tissue. The next type of cell we can see is the permanent cell. So there are three important cells to remember that are considered to be permanent. We have the neurons, we have skeletal muscles, and cardiomyocytes. These are the three permanent cells that have little to almost no replication throughout their life. So there is never the possibility of healing with the tissues from these cells that have they've originated from, but they undergo scarring with reduced quality of the tissues. And the next type of cell is the stable cell. So if we have one end being the permanent cell and the other end being the labile cell, then stable cells come in the middle. So stable cells can be anything from connective tissue, the liver and renal parenchyma, the exocrine endocrine glands. So here we can see the example of hepatocyte that is mentioned. So hepatocytes are considered to be stable cells because these have a low physiological cell turnover, but when in need, these cells have the potential to increase their use and the number of these cells after any damage has occurred, and in order to provide full recovery to the function if any damage has occurred. So the next type of cellular adaptation is regeneration. We can divide regeneration into complete regeneration and incomplete regeneration. Complete regeneration is classified as the tissue loss that is replaced both homogeneously, functionally, and structurally. So, an example would be regeneration of skin without any scarring and regeneration of the liver tissue after resection. Now, hepatocytes have the ability to restore to full size and metabolic function once they're resected. So, basically, it is said that if you resect a portion of the liver, it can grow back to its full size within a couple of months. And incomplete regeneration and following up on that point, so like I said, stable cells is an example of hepatocytes are an example of stable cells, and the other example and the next type of regeneration is the incomplete regeneration. So with incomplete regeneration we have tissue loss that is replaced by tissue of an inferior quality. So it would not be the same quality as the original tissue that was present, but it would be of a much lower quality. An example of this would be healing of the skin with scar formation. So we saw that in complete regeneration, there was no potential for scarring. But in the case of incomplete regeneration, there is always the potential of a scar to form when there is healing of the skin that occurs. Now we will be looking into the mechanism of cellular injury. And here you can see there are four images explaining how the injury takes place. But overall, we can divide cellular injury into two stages, the early stage and the late stage. So, the early stage is characterized by the reversible injury of the cell, and the late stages will be characterized by the irreversible injury to the cell, resulting in damage to the membrane, and finally, the lysis or the breakage of the cell. So, to begin, here we can see the reversible injury stage is characterized by hypoxia. Hypoxia is defined as the decrease in the oxygen supply to the tissues. So, this hypoxia to the tissues can lead to decreased ATP production because you don't have any oxygen for the ATP to be produced and function. So, this inhibits the sodium potassium ATPase enzyme that is required for the sodium potassium pump to function. So, normally the pump moves 3 sodium out of the cell and 2 potassium ions into the cell. So, if you have a decreased function of this enzyme, this pump doesn't work and we have buildup of sodium along with water within the cell. So, here we can see that increase in the sodium and osmotic pressure and increase in calcium. So why this increase in calcium occurs within the cell is because like we have the sodium potassium pumps here on present on the plasma membrane, we also have sodium calcium exchangers present on the plasma membrane. And normally what happens is we have the chemical energy of the sodium gradient um, sucks out the calcium or pumps out the calcium ions from within the cell to outside. So now that we said that this enzyme was not functioning and less sodium was being transported outside, there is all the more reason for the calcium to stay inside as well, because there's more sodium building up inside, more calcium should be present inside as well, because the pumps don't work. There's no diffusion happening because these pumps are not working. So now other features that can be seen would be the ribosomal detachment. So why do the ribosomes get detached? This is simply because we have the cellular and organelle swelling that occurs. So detachment of the ribosomes results in decreased protein synthesis. Then another point to mention is the clumping of the nuclear chromatin. So why does this happen? So we discussed about the low oxygen and ATP production. So this forces cells to in fact use anaerobic mode of respiration instead of your aerobic mode of respiration. By using your anaerobic mode of respiration, we increase the lactate and decrease the intracellular pH levels. So the cell becomes more acidic. And this results in the denaturation of proteins, eventually resulting in clumping of the nuclear chromatin. We can also see the bleving of the membrane that occurs in the plasma membrane. We can also see the aggregation of peroxidized lipids, which result in the formation of myelin figures. So, peroxidized lipids are a component of your cell membrane. And now we discuss the features of reversible injury. So now we will be looking into the irreversible injury, which is characterized as the later stages. So what exactly happens during the later stages of the cellular injury? So in the later stages, we have the phospholipids in the plasma membrane that get degraded. So you can see in this image that we have complete breaks in the plasma membrane. So we have a loss of integrity of the cytoskeleton of the cell, and we have leakage of your cytosolic enzymes, calcium leaks to the outside, and we also get activation of lysosomal enzymes and proteases, which further breaks down the cellular proteins and further damages the cytoskeleton. We also can see lysosomal rupture and release of the lysosomal enzymes. We can also see that the mitochondrial permeability increases, and as a result of this increase in permeability of the mitochondrial membrane, it releases a protein known as cytochrome C, which is associated with the activation of your apoptotic mechanisms and results in the formation of these cytoplasmic vacuoles. So we will discuss more about apoptosis in the next slides. And you can see these small dots present in the mitochondria. These are amorphous densities that occur from like the clumping of all the proteins and the release of these proteins through the increased mitochondrial membrane permeability. And in the fine and one more point to mention, so we saw the membrane rupture, and this is the most important feature to remember: the nuclear degradation effects. So the three effects that nucleus can be degraded into would be pycnosis, karyorrhexis, and karyolysis. So pycnosis is considered as the shrinkage of the nucleus due to chromatin condensation. Karyorrhexis is the fragmentation of the nucleus. So pycnosis was the shrinkage of the nucleus, karyorrhexis is fragmentation of the nucleus, and karyolysis is basically the disintegration or a dissolution of the nucleus. So this is a key thing to remember with regards to cellular injury in the later stages or irreversible injury stages of the cell. You'll almost always be asked about this. So pycnosis, once again, is the shrinkage, the fragmentation, and the disintegration or dissolution of the nucleus. And in the last stage, we have complete lysis of the cell through necrosis or apoptotic mechanisms. So we see everything has undergone fragmentation, everything has been broken down, the cell doesn't function anymore. Now we will be discussing as to what are the causes of these cellular injury mechanisms that we spoke about. So there are many causes for cells to get injured. The first cause would be ischemia. So ischemia is decreased blood supply to a tissue, and this can occur one of the main reasons for ischemia would be atherosclerosis. So, atherosclerosis is characterized by the lipid plaques that develop in the vessels and makes it all the more harder for blood to be supplied to the essential organs in the body because they obstruct the blood flow and decrease blood flow to these organs. The next cause would be reperfusion injury. So, reperfusion injury is characterized by uh, the damage to the endothelial cells that occur because of returning blood supply after a period of ischemia. In, let's say, an example would be a stroke, ischemic stroke, or a myocardial infarction. So we had a period of ischemia and we're returning blood supply. We were able to establish the blood flow back into these organs, and what happens during this process is you have the exposure to oxygen. Exposure to this oxygen can act as a foreign sort of substance. So the body is not used to this because it suddenly entered into the vessels once again. So this causes a stressor to the endothelial cells and damages these endothelial cells and also forms what is known as reactive oxygen species. These are more like toxic substances that can eventually result in increasing capillary permeability and the swelling of the tissues, and this potentially leads to cellular injury. The metabolic and nutritional causes could be malnutrition. For example, in malnutrition, we can divide malnutrition into kwashiorkor and marasmus. So, kwashiorkor is basically a decreased intake of protein, whereas marasmus is a decreased intake of calories. uh, Opposite of malnutrition would be excess of calories. So in excess of calories, this can be seen in the situations of obesity. People having obesity, they are predisposed to atherosclerosis, and this can eventually result in ischemic cellular injury, which was the first cause, like we discussed, and also vitamin deficiencies. The next cause would be physical causes. Physical causes can be further subclassified into mechanical causes like any gunshot wounds, stab wounds, fractures, thermal causes in the case of like frostbites or burns. We can also see it in electrical causes like electrical injury, radiation from ionizing radiation or UV radiation, and the next cause would be autoimmune. In the case of autoimmune diseases, we can speak about rheumatoid arthritis, systemic lupus erythematosus, and these are all basically immune responses against the body's own cells. So basically, our own body cells see our own cells. So immune system within our body sees our own cells as foreign and initiates the activation of apoptosis and damages the cells in our body. The next causes would be genetic causes that can be seen because of any altered cellular metabolism. This could be seen in cystic fibrosis because you have alteration of the CFTR gene. It can be seen in alpha 1 antitrypsin deficiency and even in hemophilia A. And the last cause would be biological causes. So, this could be because of any bacteria, virus, or parasitic infections, which can have a which can directly damage the cell, or it could be as a result of the immune response to this pathogen. So now we will look at the differences between apoptosis and necrosis. So essentially both are associated with cellular death, but there are a lot of differences between how the mechanism works with regards to apoptosis and how the mechanism works with regards to necrosis. So, to give you a brief idea about what the main difference is, the main difference is in the process that occurs. So, apoptosis is more of a programmed cell death. So, apoptosis is considered to be a physiological process, whereas in the case of necrosis, necrosis is more of a non physiological process. So this is one of the basic differences between these two terms. Now, in apoptosis, like I mentioned, it's a programmed form of cell death. So it's a physiological process that occurs because of specific intracellular enzymes known as caspases that actually activate further signaling pathways that eventually result in the shrinkage of the cell, followed by the fragmentation of the cell with formation of apoptotic bodies that get phagocytosed by the macrophages without triggering an inflammatory response. So that is one of the key points with regards to apoptosis, is that it doesn't trigger an inflammatory response. Whereas in the case of necrosis, this is the opposite. So we have an inflammatory response that gets triggered. So we will look at the mechanism now of how necrosis works. So necrosis is a non-physiological process, and here what happens is that we lose the integrity of the cell membrane because of any exposure to an infection, or it could be from any toxin exposure or any injury, and this results in increasing cellular permeability. When you have increased cellular permeability, we have the swelling of the organelles, and this eventually results in the lysis and release of the intracellular contents into the extracellular space. And by the release of these contents from the intracellular to extracellular space triggers an inflammatory response by the innate immune system. So we have so the neutrophils come into the site in order to capture these release of the contents and break it down further, and followed by lymphocytes later on. And finally, we will be talking about the types of necrosis that are present, which can easily be remembered with a mnemonic. Fun-filled life can get complicated. So fun stands for fat necrosis, filled for fibrinoid necrosis, life for liquefactive necrosis, can for coagulative necrosis, get gangrenous necrosis, and complicated for caseous necrosis. So we won't be following the same order when explaining these things in detail. So to begin, our first necrosis that we'll be talking about would be coagulative necrosis. So coagulative necrosis is a type of necrosis that is caused by the ischemia towards the tissues, which is present in most of the tissues except for the brain. So examples mentioned here would be your myocardium, the splenic infarctions, hepatic infarctions, and renal infarctions. So here you can see infarctions of the kidney. So you can see the necrosis present here in the kidney. And the pathophysiology associated with coagulative necrosis is the decreased oxygen delivery from the ischemia and further decreases in the ATP production, which forces the cells to use the anaerobic mode of metabolism. This anaerobic mode of metabolism increases the production of lactic acid in the cells, resulting in acidic pH, which eventually leads to denaturation of the proteins and causes cell death. We also can see impaired sodium potassium ATPase enzyme, and the decrease or inhibition of this enzyme causes the sodium potassium pump to fail. So we have buildup of the sodium inside the cell, which further increases the intracellular water levels, because sodium and water tend to diffuse in the same direction, and eventually causes swelling of the cell. The second type of necrosis would be liquefactive necrosis, which is defined as the softening of the affected tissue. And this occurs because of the release of hydrolytic enzymes from your neutrophilic lysosomes that digest the affected tissue, leading to softening of the tissue, followed by necrosis, and eventually resulting in cavitations and pseudocyst formation. So here this is an image where you can see the liquefactive necrosis that has happened in the brain. And the brain, in the previous slide I said that brain doesn't undergo coagulative necrosis, but in fact undergoes liquefactive necrosis. So other examples would be like your bacterial abscesses, stroke, and pancreatitis. The example of pancreatitis here would be, it is because of the enzymatic damage to the parenchyma. So in this case of pancreatitis, we have the damage to the parenchyma. The third type of necrosis is gangrenous necrosis. So gangrenous necrosis is essentially a subtype of coagulative necrosis seen specifically in the extremities. So here you can see in the foot, this is gangrenous necrosis. And we can divide gangrenous necrosis into dry gangrene, which is caused by ischemia, and wet gangrene, which is in fact a superinfection of the dry gangrene with swelling and blistering of the tissue along with pus discharge. So some of the examples are peripheral arterial disease, acute limb ischemia, intestinal ischemia, and gas gangrene. Gas gangrene is caused by Clostridium perfringens, and this condition actually is a life-threatening condition, and it is basically a necrotizing soft tissue infection that occurs with exposure to this microbe. The next type of necrosis is caseous necrosis. So, caseous necrosis is actually characterized by macrophages, epithelioid cells, and multinucleated giant cells which surround a site of infection, forming granular debris, and it walls off the pathogen. So, uh, on gross appearance, caseous necrosis is said to have like a cheesy white texture, so you can see that it looks kind of like cheese. It is disgusting, but it is grossly defined as the appearance of cheese, and examples would be typically seen in tuberculosis, histoplasmosis, and nocardia. So this is basically like a granuloma that is formed from a collection of these cells that surround the pathogen. The next type of necrosis is fat necrosis. So, fat necrosis is when we have premature death of adipose cells, either from traumatic injury, which is characterized as non enzymatic fat necrosis, or enzymatic fat necrosis. So, enzymatic fat necrosis occurs because you have these cells that get damaged from the cytoplasm. We release lipases and triglycerides are released, is eventually leading to the breakdown of these triglycerides into free fatty acids, and these free fatty acids have the ability to bind to calcium and result in the process known as saponification, and it causes, and we can see that it forms a chalky white appearance. And non-enzymatic fat necrosis is seen typically with breast injury. So, in breast injury, usually is seen in women, and it's from some trauma to the breast that usually they're unaware of. It happens in that moment and they forget about it, but this can also cause premature death of adipose cells. And in this case of acute pancreatitis, so in the previous slides, I spoke about how pancreatitis was an example for liquefactive necrosis. But in the case of liquefactive necrosis, I said that the pancreatitis involvement is specifically to the parenchyma. So we have damage to the parenchyma in liquefactive necrosis. However, in fat necrosis, we have damage to the peripancreatic fat. So because of the saponification process from the calcium binding to the free fatty acids and eventually leading to this chalky white appearance. And the last type of necrosis is fibrinoid necrosis, also known as collagenous necrosis. So, fibrinoid necrosis is characterized by the injury towards small blood vessels with accumulation of fibrin and other plasma proteins. So, we can see over here that we have the blood vessel, and we can see the accumulation of this fibrin strands and other plasma proteins. The pathophysiology associated with this is that we have deposition of immune complexes leading to the vessel damage as a result of, let's say, type 3 hypersensitivity reaction, which eventually causes the fragmentation of your collagenous and elastic fibers within the blood vessel, typically leading to leakage of fibrin and other plasma proteins. So, examples of this would be rheumatoid arthritis, polyarthritis nodosa, peptic ulcer disease. So, you can see these thick walls are kind of created with fibrin and other debris. Thank you for making it to the end, and I hope this presentation was informative for you. And thank you once again.